Great. I think we are starting. So, welcome everybody to today's Emerging Scholars Lecture. For those of you who are not familiar with this program, this is a program that the Institute for Health Policy Studies does with the University of Michigan and the University of Pennsylvania. Through a fairly competitive process, each of the campuses selects two scholars, one of whom goes to visit each of the other two campuses. So this is our first visit for this year and the first in-person visit for a couple of years. We are very fortunate to have Elham Mahmoudi, who is here from the University of Michigan. And before I give a full introduction to her and her talk, I would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Now I would like to introduce Dr. Mahmoudi. She is here from the University of Michigan, as I mentioned, in the Department of Family Medicine. She is a health economist, and she has extensive experience in using a variety of large secondary data sources, including national representative survey data, public and private administrative claims data, and electronic health records. She does a lot of quantitative analysis and econometric methodologies. So she is, true to my heart and my background, methodologically speaking. Her research has been focused on evaluating healthcare policies aimed at eliminating and reducing racial and ethnic disparities in access to care and the quality of care. Her research also extends to examine healthcare use and costs and the efficiency of care for older adults with cognitive decline, specifically Alzheimer's disease and the related dementias and mild cognitive impairment. She also studies individuals living with disabilities. She works internationally as well, including with programs in China. So the title of her talk today is Predicting 30-Day Hospital Readmission Among People with Alzheimer's Disease and Related Dementias. So I will hand it off to you.
Thank you so much. Hi, everyone. So this is, I'm Elham Mahmoudi. Thank you for your nice words and introduction. So without further ado, let me start the topic of the talk today. You can obviously put your questions in the chat, but I'll try to finish this within 45 minutes so we have time for question and answer at the end. But at any point, there are two sections into this talk. If you feel you need to ask the questions, please go ahead, unmute yourself and ask the question. So I'm not going to go through the details. I'm assuming people who are attending the webinar and those of you here are familiar with the facts about Alzheimer's disease and related dementia, ADRD. We know that the prevalence of ADRD is increasing rapidly. And although patients with ADRD represent only 10% of older population, the cost of care for them is about more than 40% of healthcare costs, direct and indirect, if you put them together. And for example, on average, Medicare and especially Medicaid spend 3 and 23 times more for people with dementia compared with other older adults. So the estimated healthcare cost for ADRD is about $300 billion. That's the estimate for 2020, and I'm assuming it's increasing. So as an economist, why I was interested to make the healthcare system more efficient for this patient population. And it makes sense to me to focus on hospitalization because hospitalization is one of the most expensive sector of healthcare system, especially in the United States. And we know that both incidence of hospitalization and readmission and potentially preventable hospitalization in general is much higher among people with ADRD, again, compared with general geriatric population. So the idea was, and the fact is not just the cost, the fact that it's no value added service to, especially to this patient population, because research has shown that hospitalization increased the risk of long-term institutionalization, premature mortality, and it's just delirium. It's just delirious, and it's just not adding much value to patient and their caregiver in general. So the idea was to leverage the rich set of data that we have in electronic health records to provide a real-time, on-time data, not only for research purposes, but to act upon it and hopefully identify people who are at risk of readmission, and by acting upon this knowledge, reduce the risk of readmission for this patient population. So this is basically is the conceptual model, is the process of inpatient care in the United States. And the idea was to use this opportunity at the time of index admission till discharge to gather information that's readily available through electronic health records, to have information to act upon at the time of discharge and make the right decision, targeted right decision for patients with ADRD or people with cognitive decline in general, because we are all aware of the difficulties of diagnosis of dementia. So these are some of the preliminary data that we did. We used for these graphs that I'm showing you. We used Michigan Value Collaborative data. It's the consortium of about 80 hospitals in Michigan for just hospitalization inpatient data. And as you can see in the green graph, green bars represent the readmission rate, and the pink or peachy color shows the cost. And again, as we mentioned before, both rate and the cost of readmission is much higher among ADRD population. And this is a socioeconomic issue. As you can see, it's not universally the same. Again, this is a map of Michigan. Those that are highlighted with red were those with higher readmission rate, and they match exactly with disadvantaged areas or counties in the state of Michigan. And I'm sure that's a universal concept. Just similar to potentially preventable hospitalization, readmission, 30-day readmissions are almost the same. So to start the process, we did a systematic review. I was very interested, and again, this project relates to my Career Development Award, K Award. So I was new to ADRD, and I'm not a computer scientist. I'm an economist. So I was getting into this territory. To understand what's going on, we start with a systematic review of all predictive models of readmission that used electronic health records for their model. What we found out, it published in BMJ, and what we found out was that these models are, the use of these models using EHR systems are on the rise. And lab results and vital signs that are available in EHR systems versus claims data or survey data showed some lift for some of the models that have been used, that we studied, and use of natural language processing to basically tap onto the rich set of information available in text, in medical notes. However, at the end, on average, the accuracy and power of this predictive model of readmission relatively stayed low. So, and that's something that I wanted to discuss as well at the end. Spoiler alert, our predictive model for the readmission wasn't that great either. It was better than what we have, the status quo, but it wasn't great. And that's something that still a mystery to me, and I opened the door for discussion because I think that's an interesting topic. So to begin with, I why do hospitals need a good risk assessment tool for readmission to begin with? The idea is that we have limited resources and hospitals are expensive. We have limited number of providers, nurses, care coordinators, and therefore, if we wanted to manage this patient who we know have high demand for these services or are high need patient or in the high need patient group, we need to intervene in a targeted way, in a tailored manner. Currently, hospitals use the LACE, many hospitals, not all of them, use the LACE index score, at least in Michigan Medicine we do. LACE is an index that was developed in 2012, if I'm not wrong, in Canada using claims data. It's very simple. That's why those hospitals that use Epic system, most of them, again, not all of them, implemented LACE into their system as a risk assessment tool, but it's really not doing well. To summarize, this is what we get from a LACE index score, and to me, it's a black box. It's the beauty of it is its simplicity, and that's why so many hospitals implemented that into the Epic system. But it's based on length of stay. They get points, acuity of the admission, type of admission, basically, comorbidity index, what score do they get, and number of ED visits within the previous 6 months. But again, it doesn't do a good job. It's like a chance. It's a 50-50% chance. So to begin this process, we use Michigan Medicine electronic health records. We had demographics, age, sex, etc. already in the system. Lab results and vital signs were available. What we did for lab results and vital signs, to make them ready for modeling, we spent time with a geriatrician and make them basically specific for this patient population. Looking at the range of the data that we had and make it, is it normal or abnormal based for this specific patient population for adults 65 and older with diagnosis of ADRD. Health encounters and prior use and cost is again readily available in EHR data. What we developed and constructed was the frailty index, which wasn't available in EHR data. I have the citation here. I really recommend this paper published in Lancet in 2018. They developed and validated a model to estimate the frailty index using EHR system and validated in claims data as well. Frailty index is a combination of all your chronic conditions and include functionality into, it's not just the comorbidity index, it's way more than that because functionality is included in it as well. So based on the chronic diagnosis of chronic conditions that we have, we constructed frailty index for our model. We also included all their diagnosed chronic conditions in the model as well. Second, we geocoded because we had the patient's addresses. We geocoded our data. I don't know if you're familiar with National Neighborhood Data Archive, in short, NANDA. It's publicly available. If you have the patient's address, you can merge your EMR data with at the tract level, census tract level, which much smaller than zip code level, with that data set. So we got two constructed is a composite measure, disadvantage and affluence. They measure different things. For instance, disadvantage is based on certain variables like mean of proportion of population in poverty in that area, unemployment, non-Hispanic Black, those who live with public assistance, and female-headed families with children. And for affluence, they use a different set of variables, such as employment in professional or service industry, proportion of households with income greater than 75K, so on and so forth. So there are two different data sets, and in research, they use both of them in their analysis. So these are the two included. The other thing that we did, we matched our data with Michigan Value Collaborative, again, the hospitalization, because many people, if we don't, they might not readmitted to the original hospital, in this case, Michigan Medicine, they might readmitted elsewhere. Michigan Value Collaborative has access to Medicare and Blue Cross Blue Shield. So we had about 70% match that tells us if patient got readmitted elsewhere, but Michigan Medicine. So this is, and I apologize if this slide is small, but I just want to give you an overview. We had about 171 variables in the model. Again, basic demographics that we usually include: age, sex, pair, race, ethnicity. I should say socio-demographic variables. We had health variables. I included all hierarchical conditions in our model, median BMI, frailty index that we constructed, number of medications that they used, and characteristics of their index admission, what type of admission, length of a stay, what day of the week, weekend versus weekdays, and then we talked about those two: disadvantage and affluence variable, prior healthcare use, and then lab results and vitals, which we actually make them binary variables based on our work and discussion with an expert geriatrician. So these are the variables that we put in the model. I'm going to go jump into the results section. And again, I know this is a very crowded table. Let's just focus. I just wanted to show you our patient population. We had about, and this is both training and test set, our table one, if you will, about 2,800 people with dementia. About the rate of readmission was about 25%. The things that stand out, they are sicker individuals based on Elixhauser index, 12.1 versus 10.6 for those that not readmitted. And frailty index obviously is higher. That's what we expected for people who got readmitted. Percentage of Blacks and Hispanics are much higher than whites for readmission. Again, anticipated. Length of a stay is higher. Prior use in ED and inpatient services is higher among those who got readmitted. All of it, I think, kind of makes sense. So these are the results, and we used multiple models such as random forest, XGBoost, logistic model, and then I'm going to talk about the last model that we used, generalized additive model, because it was more interpretable, and we're going to talk about that. And again, I apologize for it to be so small and crowded, but let's focus on the top. These are the risk factors based on the random forest, which came out as our best model as a predictive model. The top risk factor is length of a stay. The higher it is, the higher your risk for readmission. Frailty index, prior to index admission, frailty index, because that's frailty index is something that's changing, came out second. The affluence, if you live in a more affluent area, that was a continuous variable, your risk is lower. And then we have BMI. Actually, we have a BMI paradox here. Our model shows that, and it's supported by research, that if your BMI is, not that I'm encouraging higher BMI, but lower BMI basically increase your risk of readmission versus the other way around. And living in disadvantaged area obviously increase your risk of readmission. So let's take a look at, so before I start talking about our last model, GAM model, I want to show you a range of these machine learning models, because there's a lot of discussion about that. The whole purpose that started this project was for it to be interpretable, to act upon it specifically targeted for care coordinators, knowing why patient A is at higher risk compared with patient B. So there is a range between accuracy and interpretability. Models such as neural networks are extremely accurate, but they're black box, versus logistic regression is not that flexible, but it's very interpretable. So to get to the to have some models that are interpretable, white box models, we use this GAM model, and we use an off-shelf package. We use R, by the way, for all these programmings. Dr. Richard, if I pronounce his last name correctly, Caruana of Microsoft actually developed this package first in R and then in Python. It's very nice because for each of the variables or data features that you use in your model, it tells you in what range. It gives you the distribution, and it tells you when the risk goes up for that patient. So before further ado, let me go through those 5 variables specifically. Length of a stay, for instance. This is the distribution of length of a stay. The first model, in the x-axis, we saw the number of days during the index admission. And then the score is something that it's a risk score, but it's convertible to something like odds ratio. It's based on an exponential. So if you put e to the power of 0, it gives you actually the risk factor. You can convert it to odds ratio. And the lower graph, it's the density. So these highlights are actually confidence intervals, which is very nice. Again, the confidence intervals, when they are very wide, that's when you don't have that much sample, so it's not that reliable. But let's take a look at this, for instance. When the length of a stay goes past 3 days, we see a small jump in risk of readmission. When it goes past 7 days in here, we see a huge jump in risk for readmission. However, because look at the distribution is small, we didn't have a large sample. The confidence intervals are kind of larger compared with the previous set of data, and it stays high for a while. And then for this set of data that it goes flat, we actually didn't have that much data. For frailty index, again, as we can see, if we kind of interpret it from here, because we didn't have that much data here, we see that it's flat for a while. When the frailty index increase, we see a jump in the risk for readmission, and again, it stays flat afterward. Here is the affluence variable. The higher the affluence, the lower the risk, and you would see that when we move and the x-axis forward, the risk actually comes down and reduces. And for the BMI, we see the opposite. It's flat for a while. It comes down here, and it basically it comes down lower as the BMI, which is again in x-axis, increases. And the same issue with the disadvantage. We see it here flat. When it goes up, the risk increases and it stays flat for a while. Again, you have to look at the data. So this is the end results, basically, the measures that usually computer scientists report for the accuracy and sensitivity of the model. I also reported the latest score. Our best model, accuracy-wise, was random forest. Compared with LACE, we did have a better score than LACE, but really AUC of 0.66 is not acceptable, is not even a good model. And with all the variables that I explained be included in the model, it's a dilemma that I would like to discuss if we have a chance. Why is it staying low? And it wasn't just ours, other models that I explained we use in the systematic review were almost in the range of 0.70, which again is not a really good model. So I can keep going, or we can stop here and answer question, because the second part of the talk is really about, we knew that it is about caregiver and using NLP and medical notes. So should I continue and leave the question and answer at the end?
My question was possibly related to where you're going next in your talk, so I think we should.
Okay. All right, which is more innovative and interesting. So one of the variables or data features, if you will, that it's very interesting, especially for this patient population, is availability and type of caregiver. And it's not available in a structured data. And that's a thing that we were talking last night with a group of colleagues. It's really hard to add. The simple answer would be, oh, then why healthcare system don't ask that question? It's very hard to add to the load of variables that we are adding for people to be collected, both from provider sides and patient side. Hopefully one day we'll get there. But until we get there, we thought we can use, that was an exploratory aim because we didn't know if it's successful or not. But we thought we can take a look at medical notes and see if there is a caregiver available for this patient cohort. In Michigan medicine, we have about 60 different type of medical notes, and it's hospital by hospital. These medical notes are different. Some of them are based on templates. Some of them are really just free text with no template, and the text varies from notes to notes depending on who writes them. Some of them are written by providers themselves, some are by nurses, medical social workers, medical students, you name it. So we went and with the students, we went through all these 60 different type of medical notes, sampled them to see which one is more promising. And the one that we found most promising were telephone encounter notes that are usually based on the conversation that they had either with patients or caregiver of the patients about various topics. So we used 2016, 2019, the same cohort, we used basically their medical notes. And we applied the rule-based natural language processing and again, use R package. Python is usually the software to use for these things, but again, I'm new to this machine learning process. So we use R for that. And we defined, the goal was to quantify four things, four outcomes to answer if the patient resides at home, patient resides in an institution, has a formal caregiver, has an informal caregiver. Formal caregiver is a paid, like a nurse, or someone who is paid to provide caregiving. Informal is family members or friends, or anyone who doesn't get paid for the job. And the reason that these are not mutually exclusive, because there are people who actually use daycare during the day. We consider that as an institution and then come back home at night. So both can be at some period of time, one or zero. They're not mutually exclusive. And what else? And the same for caregiver. A person can have both a formal and informal caregiver. And the analysis was at the note level with the idea that we actually sort all the notes for each patient. But the idea is the patient might have a caregiver at point A, but lose that caregiver in point B. And that's what we found out in the notes, because a daughter or son were available for certain time period, but you can't assume that it will stay. So the analysis was at the note level. We divided our, again, notes into two sets of training and test set. And this is our schematic flow diagram. We tested about unique number of patients were about 227 people. Let's take a 223, I'm sorry. This is a previous slide. So we used telephone encounter notes, about 300,000 of them, 300,000. We divided them into training and testing, and let's take a look at, again, this is our table 1 based on patient cohort, the same patient cohort that we studied before. We just want to make sure that it matches with the average that we had in the past. And we randomly selected these notes for the analysis. And the reason that the numbers are lower, this is a very labor intensive process because we had to manually check them, all these notes, against gold standard, which is chart abstraction, and reading these notes. So 2 people blindly read each of these notes. We train the algorithm based on the rules that we define in our data dictionary. And when we are satisfied, we didn't touch the testing set and we just ran the algorithm. And these are the end results. And that was in contrast with our readmission model. We had a really high accuracy for the main one, for informal caregiver. The accuracy of 0.96 is, I think, phenomenon. And both the sensitivity and specificity was high for informal caregiver. We didn't have the institution, if they were institutionalized, the measures were not that great. And I think part of it was going back with certain things. We talk about that, like misidentifying these places. Let me go to this screen. Incomplete information, misspelling of the information, uncertainty that involves in the medical notes, like the name of these institutions were not completed or correct. And just to let you know, for our algorithm, we downloaded the set of CMS from CMS, all the SNFs institutions in Michigan. But the fact is, they're just like mom and pop shops. There are lots of places that are not included in any database. So I think our data set to check against to see if the name of these institutions is in our database was not complete. We added another list from the hospital for Washtenaw County, where Michigan Medicine locates, but I think we had an incomplete set of information. So there are a lot of work to do if we are interested in having an accurate information for institution. And I want to give you an example. This is funny because depending on who writes these notes, you find really silly abbreviation. For instance, daughter was DTR or DAU for daughter sometimes. And it's just, there's this saying that you read one note, you read one note. You can't generalize. It's very hard to do. So we need to work on the algorithm basically to overcome these challenges of NLP. So this is the end of my talk, but things that I'm very interested, we are right now using the same approach, NLP, to determine social determinants of health for the same patient cohort, because as an economist, I firmly believe that these social determinants of health is extremely important in adverse health events. They are the main risk factors, and we're looking specifically at like food insecurity, transportation insecurity, social isolation, housing insecurity, and so on and so forth, using the same NLP approach, using at medical notes. The other thing that I'm interested, and I talked with some of you prior to the talk, is in Michigan medicine, we, due to COVID, and I'm sure elsewhere, we started this care at home program, hospital at home or remote monitoring. I think there might be this accidental thing that happened because of COVID might show us a way to care for people, older people with dementia, that hospitalization is really not adding any value for their care. So I'm evaluating that at the same time, using our electronic health records. And basically that's it. And I'm looking forward to collaborate with you. I have a lot of questions. In our team, we have medical social workers, nurses, geriatricians. It's really a team effort to, I think, provide a better care for this patient population. Before I finish, I really like to acknowledge and thank my primary mentor, Julie Bynum, co-mentors, Vinod, and I don't dare mispronounce his last name. He's our computer scientist for NLP. My mentor, Karen Deepsine, is also helping me with the machine learning approaches. And I work with brilliant graduate students who are expert in R and machine learning. That's all I have. And now I guess we have time for question and answer.
Wonderful. So anybody who's participating on Zoom can type in your questions into the Q&A box, and we will moderate those for you. I will kick it off with a question. So I think I see where you're going with the natural language processing and the readmissions prediction, because the prediction models based on the data that are structured in the EHR aren't very predictive, as you put it, not a very good model. And the first thing that came to my mind was the availability of home care. I know that there's some literature that when people have good home care, and I think that includes both formal and informal, that it reduces the frequency of physician office visits. And so we did a small evaluation, so I can't wait to talk about evaluation with you about type programs. But yeah, I'm curious what other things you and your team speculate would ideally be added to readmission models, and the challenges that you're experiencing trying to find that data or trying to incorporate it.
Yeah, that's a great question. And honestly, I don't know if I have the answer, but reading the medical notes, and it's painful, it's sad when you read these notes, but I think it's very eye-opening. Many of these people, even in Washtenaw County, which is relatively has higher average income, it's not a very diverse population, and that's why I really like to collaborate to test this. Our sample size was small for machine learning purposes, but one thing is many of these people are alone despite their dementia. When we read the notes, we see that they didn't have anything to eat. They just ate canned foods. I have the codes here. I can't get to my office because I cannot drive and my daughter is not available to take me. So these are the things that we cannot include. It's not included in our model. It's unobserved. So I'm putting a lot of hope in this NLP piece. It's exploratory, and rule-based for those computer scientists is like a basic. It's just like descriptive table for our quantitative people. We don't even look at it. It's just unadjusted average. Rule-based is the same. So it's really the first step. But I see that we can get more out of it, getting more sophisticated out of this NLP. And we had good results. If we can, and we ran this, I don't think I showed that table. We ran our NLP model for caregiver against all medical notes that we had, not just to get it to see how it runs. And we got good accuracy for all the models. We didn't obviously match them, validate them, but we could identify caregiver availability using other nodes, which is promising.
Questions from our Zoom audience? I do not see any typed in yet. Oh, we have a question. Excellent. So Kate Pawson, who I think you were meeting with
Yes.
or have met with, says the NLP piece is really exciting. And I think your work here will be foundational for so many studies. So thank you for this work. What is your plan to look at whether caregiver variables predict readmissions? And how about, is there any potential to use advanced care planning documentation or goals of care documentation in these analyses?
Oh, very nice. Yeah, that's a very good question. The first question, to answer the first question, and that's a dilemma. We actually use the estimate that we got for caregiver availability, for informal caregiver. Remember, we converted to a binary variable. We inserted back to our model. It didn't come out as the top 10 or 20 risk factors to predict readmission. But I have to look into it. So we need to, again, look more carefully into it and see why or why not, because to me, that's one of the main factors. The other thing to consider is this was really for the caregiver, the first step. The second thing that we like to do is to identify how many hours a day these caregivers are available, how far from the patient they live, because all of these have been shown to be effective in predicting any type of adverse health events. We only identify if the caregiver exists, but sometimes they live in next door in the same house, sometimes across the country. So that's important. But we didn't use advanced care planning notes. Maybe we don't have those in Michigan medicine. I'm going to go back and look. That's a good type of note to look. But again, that's why it needs to be multi-center and generalizable, because we might not have them. I'd be dubious if you don't have them in Michigan. That's something that I should expect. But I give you an example. For instance, for social determinants of health, we used, based on our social worker in our team, we used progress notes that is written by social worker when a patient is hospitalized. And that was the most promising one. But I haven't, that's a good type of note to look into. I haven't.
I have another question. How was calibration of the readmission model? Was analysis performed with the decision curves comparing your readmission model to the LACE model?
That's a very good question. We are in the process of doing it. We haven't done that. We ran some calibration model. I should do it, compare it with the LACE, but we haven't done that. But all our numbers was better than LACE by about, I would say, less than 10, a little bit less than 10%. But compare with LACE, it was better, but it wasn't a good model. But we're working on the calibration, running the calibration models. Yes, the curves.
So I'm curious, clearly the prediction models for the readmissions are not very good. If a individual on their discharge or hospital discharge is flagged at being at higher risk, even with a mediocre model, then what happens?
That's that's a good question. Are you talking about the current system of care?
Right. And the current system of care, is there, in Michigan, for example, is there a systematic on who the discharging team is, and what would, kind of what would be pathways to test intervention to, if you had a model that you
Okay.
trusted to begin with.
Yeah. So that is the third aim of the my K proposal. I will be shadowing the discharge planner to see how they are doing their current job right now. And basically, this is kind of mixed method analysis, interviewing the discharge planners, care coordinators, and then patients as well to see how it works. But I can tell you from the notes that we do have a system. It's not really ad hoc, but it's very easy to lose the patient in this process. Based on what I've read in the notes, like if you consider as an at-risk patient, um, the care coordinator will contact you or your caregiver for the follow-up appointment. They put you in touch with the pharmacist. And but if you don't show up, I've seen over and over in the notes, if you don't follow up, if you don't get back to them, they just write a note that we left a message for patient, nobody get back to us. And that's the end. They don't have a person, at least under the current system, a nurse to go check on the patient, see how the patient is doing. And that's why I'm very interested in this. I call it hospital at home. There are different names in different institutions for that, or home at home, care at home. It just started not because of this patient population, but because of COVID to empty out the beds. But we don't have that for in general systematically. It's very limited because I believe in 2020 Medicare passed a law that enabled that because of COVID specifically. But that's why I'm interested in evaluating this and see if we can expand that beyond COVID, not because of COVID, but for this patient population. But to answer your question, reading the notes, I know it's very easy to lose the patient in the process. If the patient doesn't get back, the caregiver will not reach out.
Yeah, I do have to laugh about your comment on that. You're talking about some of what my husband and I are living right now with my mother-in-law.
Yeah.
And I got her whole medical record because she was moving and changing providers. And it was like the system flagged that she hadn't filled XYZ prescriptions
And that's
for
it.
months.
Yeah.
So the pharmacist calls her, as they should.
Yeah.
And she says, oh, yes, patient indicates that she understands and will fill the prescription.
Yeah.
And, when we figured out the
Yeah.
degree of cognitive decline there was, it was like, I guarantee you she did not start taking her medications after the pharmacist called because she forgot, because she
Yeah.
had declined.
Yeah.
So it's like, well, then, what the difficulty becomes for a system, how much do you reach out? How do you reach out?
Yes.
To what degree does the family know that there is a need?
Yep.
To what degree is their family or friends who are capable of filling in that
Yeah.
need? And kind of then what? And I mean,
Yeah.
talk about a big, hairy problem.
Yeah. 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 I share the experience. I lost my dad due to COVID, and my mom was living with me for a year. So I was very much involved in, and she doesn't have dementia, but she's an older person. So I took care of all the medical contact. And I see through the portal, yes, they send a message that you need this and this or this medication. But if I'm not on top of it, my mom wouldn't check these things. You see, it's extremely easy to lose a patient in this process. So how to, you're right, how to not lose the patient is a big dilemma because we don't want to act like a big brother, but at the same time, you don't people are free to do what they like, but when they're not capable of interacting with the healthcare system and their health is deteriorating, what are the boundaries? How can we approach? Is the nurse allowed? Like I remember when I gave birth to my son, the nurse would come home to visit you after they release you from the hospitals. They check everything at home. And we do the same for this hospital at home program. And it has been shown, the preliminary results show reduction in adverse health event, in ED visits, in hospitalization, in mortality. Because we are at it, we monitor these patients all the time. But I think in general sense, we just lose these people.
Yeah, and I think the patient portals, to your point, those are increasingly available. But as people who were in their late 70s didn't grow up with computers.
Right.
I didn't grow up with computers
Yeah.
even.
Yeah.
But somebody in their 70s didn't adopt computers until they were, truly
Yeah.
in kind of midlife.
Yep.
Maybe never had them for their careers.
Yeah.
And so the idea that that is going to maintain this as the standard of communication as there's cognitive decline seems completely like, why did anybody actually think that that was going to happen? Or if they did, it was a completely irrational expectation.
Right, right. Like, for instance, just another example, wellness visit is now covered by your insurance, Medicare or elsewhere, but it still remain very low. And I know through anecdotally through my mom, if I didn't make her appointment and she's functional and aware of everything, she's just older and not familiar with the technology or not following the health news, she would not go for her appointments. Easy as this, regardless of it's covered or not covered.
See, I'll put out a last call for our Zoom attendees. The Q&A box I have it open. Any other questions from our audience in the room? Right. I think then we are nearly at the top of the hour, so it is a good time to give you a break and thank you for coming to present this work.
Sure.
We were recording, so the recording will be also shared for anybody who was not able to come in person or join in Zoom. But I am really glad that you were here. It is so nice to be able to do these events in person again.
Yes.
Even though people are still trying to figure out how to do their commutes and readjust to a hybrid world. So thank you for coming and being part of our experiment.
Thank you for having me. And as I said with people who I met, I'm really looking at trying this. This is a dilemma, using a multi-center approach because we can make it generalizable. We have a larger sample size. So I'm looking for collaboration and ideas and just discussion on this topic. So please reach out. You have my email here, so I look forward to collaborating with you in the future. Thank you for having me.